صباح الخير طلاب. Good morning. I am Dr. Zuhair Al-Johar. Today we'll speak about myasthenia gravis, which is sometimes called the ragdoll illness. يعني يصير العضلات مثل الخرقة، يعني ragdoll illness يعني. Because it causes flaccid muscle weakness. It's the main feature of it. Here, to know the objectives of our lecture is to mainly be to familiarize ourselves with the presentation of myasthenia gravis. The point is that myasthenia gravis is actually a rare disorder. But why we are studying then a rare disorder? Because it is potentially life-threatening. It can lead to death, and most of its victims are young age females. So it leads to death at a pretty much very important age group. And it is really rare, and that's why one needs to familiarize himself with it in order not to miss this potentially life-threatening disorder, which is often missed and is often lately diagnosed. Many patients with myasthenia gravis will be labeled as having some rheumatologic disorder. They would go to rheumatological clinic and so on, and without having any diagnosis. So most of them arrive late, really, and many of them actually arrive in crisis. So one of the main objectives of this lecture is to recognize the kinds of crises in myasthenia gravis, and when they are presenting, how we are going to prevent further increment in these crises, or even if a patient comes with myasthenia gravis, what we should do in order to prevent him going into a crisis, and of course how to initially manage these cases with the crisis, and also how to follow up patients in the wards, myasthenic patients in the wards. So most of our lecture will be delivered on the subject of myasthenia gravis. We need to know that myasthenia gravis is not the only neuromuscular junction disorder. There are other disorders like Lambert-Eaton, but we won't speak about them here. This is left as homework for you. You can read about it in Davidson. So we concentrate on the main neuromuscular junction disorder, which is myasthenia gravis. So now the mechanism of myasthenia gravis. Myasthenia gravis is an autoimmune disease which is directed against the neuromuscular junction. And the cause of that, what triggered that autoimmune disease, what caused it, is actually, as most of the cases of autoimmune disorders, it's unknown. It's idiopathic. We'll speak about this mechanism. We'll have some videos on it, which tells us the details about that mechanism. So I'll present it to you. Here I'll speak to you a little bit about the clinical picture. I'll also show you videos about these clinical picture in order to familiarize yourself with it. So pretty much myasthenia gravis is a chronic disorder. So it runs for years really, and it has a relapsing remitting course. So you have several months in which the patient is deteriorating. Possibly he's free for many years and then he deteriorates. Sometimes you have more severe cases. Sometimes you have milder ones. As I said, it affects usually young females, like females in the age of adult females most of the time, in the age of 20 to 40. But it still also has a bimodal distribution. It also affects elderly males this time. So it affects young females and elderly males, and it's unknown why this bimodal distribution occurs. We don't know why it has that distribution. As I said, it's potentially life-threatening, and the main mechanism of life-threatening is through respiratory failure, which is type 2 respiratory failure. And it's characterized actually by fatigable muscle weakness, and usually proximal muscle weakness with cranials actually. So patient will present to you with ptosis, difficulty in swallowing, sometimes head drop actually, and with the various manifestation of peripheral weakness, like you see proximal muscle weakness of the upper limb, like the patient cannot elevate her arm, especially when she wants, for example, to comb her hair, or then difficulty in walking or going upstairs, sitting, starting from sitting position, and so on. So you'll have proximal muscle weakness coupled with cranials actually. This is the most common kind of presentation of myasthenia gravis. Sometimes it's limited only to the eyes, which will be called ocular myasthenia. But most of the time it's general, so it's not just ocular. It involves the ocular muscles and other muscles of the body. So this fatigable muscle weakness is usually variable. What we mean by variable, it is not of the same intensity. Most of the time it has a diurnal variation. So when the patient wake up in the morning, usually the patient is very well. He doesn't have much of weakness, but as time go by, he will develop more weakness, and usually this weakness is fatigable, painless weakness without any pain. So the more effort the patient make, weakness will come about. So usually the disease will become worse at the end of the day. And it's usually can run a variable course. I mean, it depends on the activity of the patient. So it's variable from time to time. And not only variable from time to time in intensity, it's also asymmetric. It's variable in location. So sometimes you see ptosis of the left eye. Tomorrow you will see ptosis of the right eye, sometimes bilateral, sometimes the left upper limb, sometimes the right lower limb. So it's bizarre. It doesn't have a specific, it is not fixed to a specific location. So this bizarreness of presentation, you see it on the left, you see it on the right, and the cranial, sometimes in the upper limb, you know, with the variability of intensity of this weakness. Sometimes you see the patient very well, sometimes you see him in crisis. So this variability in time and variability in space, let's say, of that disease is characteristic actually of neuromuscular junction disorders. So you should think always of myasthenia when you have patient coming to you with such a history where there is asymmetry and variability. And actually there is no signs usually referable to nerve involvement, like autonomic signs. Although autonomic signs can happen in Lambert-Eaton, myasthenic, it's called syndrome. This is not myasthenia. Actually. In myasthenia, you don't see autonomic manifestations at all. And even sensory manifestation, you don't see real, genuine sensory manifestation. Possibly some psychogenic loss of pinprick sensation happen, but not a real one. I mean, on examination, you won't see it as a kind of real sensory loss. So you don't have sensory loss, you don't have autonomic, you don't have loss of reflexes, unless there is associated myopathy, which can occur very late in the disease, and this is very rare. Most of the times, patients with myasthenia gravis have normal reflexes, so they just have fatigable muscle weakness that's painless and variable and asymmetric. And as I said, the cranial nerve usually tend to be initially affected, but not always. I mean, the disease have a variable picture, so it's not always like that. So this is pretty much the clinical picture. and the worst scenario of it is that it is life-threatening. Can be life-threatening. So here I'll present a video which speaks generally about myasthenia gravis, and then after that I will speak about its pathophysiology and how to further manage it really. So you can see this video.
Myasthenia gravis, or MG, is often called the rag doll illness because it causes patients to have muscle weaknesses, muscles that they can't control without treatment. This patient, for example, is trying to smile. The more effort she makes, the weaker her muscles become. There are around 10,000 sufferers in the UK and Ireland. So what is myasthenia gravis? It's classified as an autoimmune disease, a condition which means that the body's immune system actually attacks itself, weakening the voluntary muscles that control the eyes, the face, throat and limbs, and the muscles that help us breathe. So if it isn't treated, it can be very dangerous, even life-threatening, and hence the word gravis in the description. Very often the first signs are droopy eyelids or double vision, with weak facial movements or a changed, often rather more nasal voice. More seriously, patients might have trouble with swallowing or with breathing. When swallowing is weak, patients can actually breathe in particles of food or drink, often without realizing it, and get pneumonia as a result. The arms and legs can also be affected, as you can see in this clip of a sufferer who's not taking medication. The cause of the weakness is actually very complicated, but it's important we understand what's happening because it tells us how we diagnose it and how treatments work. If you want to move a muscle, for example in the arm, then the message to do so starts in the brain and travels as an electrical signal down the spinal cord to the nerves of the arm. The muscle contracts in response to the signal. What happens at this neuromuscular junction is fundamental to our understanding of what happens in myasthenia. The problem is at the gap between the nerve and the muscle. When the electrical signals reach the end of the nerve, they cause it to release a chemical called acetylcholine, which diffuses across the gap and binds onto special proteins called acetylcholine receptors. That triggers off an electrical signal in the muscle, which results in the muscle contracting. When you want to relax the muscles, the messages stop coming down the nerve, and with no more acetylcholine, the system resets itself. The trouble in myasthenia gravis is that the immune system destroys some of the acetylcholine receptors, so there are too few to trigger the muscles efficiently, resulting in muscle weakness. And the harder patients try, the weaker they become, as you can see here. But with the aid of drugs, walking unsupported is possible. Because MG is relatively rare, many doctors may not have come across it before, but diagnosis will become apparent when the patient complains of variable, painless weakness and fatigue. A simple test is to see how long the patient could hold up an arm or leg, or stare in one direction. Blood tests for the damaging immune antibodies will help diagnosis, and electrical tests on nerve to muscle efficiency can also confirm it. Myasthenia gravis can affect anybody of any age, and at the moment it's not curable. But it is manageable with medication to stop the breakdown of the acetylcholine ignition keys at the neuromuscular junction so that they have a better chance of triggering. Much more research is needed to find a cure and to discover what causes the autoimmune reaction to start with. In the past, myasthenia gravis, if left untreated, often caused death. But thanks to a series of breakthroughs in treatment, that is now very, very rare. But the disease is still incurable. Thank you for taking the time to learn about myasthenia gravis and the MG Association.
So now back to the pathophysiology. So as I said, it's an autoimmune disease, and the autoimmune disease is mounted against the muscle membrane actually. So it's in the postsynaptic side. Although Lambert-Eaton actually occurs at the presynaptic site, but in myasthenia it's postsynaptic, and it's due to a humoral immunity. There's antibodies produced with the complement-mediated destruction of the muscle membrane. So here we will see a video that speak about that in details, really. That's the video.
Let's review normal muscle contraction, but at the cellular level. First, you've got your motor neurons that release the neurotransmitter acetylcholine at the neuromuscular junction, which then binds to nicotinic acetylcholine receptors on the muscle cell membranes. Binding of acetylcholine to its receptor activates a chain reaction in the muscle cell that ultimately results in muscle contraction. But what happens in myasthenia gravis, though? Well, remember that it's an autoimmune disease, and specifically one that's categorized as a type 2 hypersensitivity, which causes cytotoxic injury, meaning that it results in the lysis or death of host cells, which is mediated by autoantibodies, which are antibodies that are specific for our own cells or proteins. Alright, so in this case, the patient's B cells inappropriately make antibodies that bind to nicotinic acetylcholine receptors on the muscle cells. Once acetylcholine receptors are bound by the antibody, they're unable to bind the acetylcholine, and therefore they don't respond to the contract signal from the central nervous system. Anti-acetylcholine receptor antibodies can also activate the classical complement pathway. Now, the complement system is a family of small proteins that work in an enzymatic cascade to fight off bacterial infections. The activation of complement causes inflammation and destruction of the muscle cells, and reduces the amount of acetylcholine receptors on the surface. Now, a minority of people with myasthenia gravis produce another type of harmful antibody called muscle-specific receptor tyrosine kinase antibodies, which attack proteins inside the muscle cells instead of nicotinic acetylcholine receptors on the muscle cell surface, but they similarly lead to destruction of healthy cells. In very rare cases, myasthenia gravis can present as a paraneoplastic syndrome, which means that an underlying cancer like bronchogenic carcinoma or thymic neoplasm, also known as thymoma, generates an immune response which results in the generation of autoantibodies.
So you see, this was a video, clarifying video. You see how the postsynaptic muscle membrane became very simplified. The folds that began with big folds at the beginning, like those, and now it ended with a simplified membrane. This simplification, of course, decreases the surface area of it, and it decreases the amount of acetylcholine receptor antibodies. So even if acetylcholine comes out from the presynaptic membrane, still it doesn't have enough receptors to take it. That's why patients become fatigued easily. So now, how to diagnose myasthenia gravis? The main idea is to demonstrate fatigability. So we can demonstrate that clinically, and we can demonstrate that on the level of EMG nerve conduction study, which means electrophysiologically. So this is the first thing to do, and then we will make investigations about the underlying autoimmune response which is causing that, and we can even investigate a possible cause for that actually. So first we go to bedside tests. The simplest test is the Simpson's test. With Simpson test, you ask the patient to gaze upwardly for about 30 seconds. So you tell him to look at the ceiling, and by that the patient will elevate his upper eyelids. So this elevation will be sustained because he will continuously look upward on the ceiling, and that will cause the muscle to fatigue and will produce ptosis. Now the tensilon test. With the tensilon test, actually, what you do, the tensilon test actually administer a short-acting anticholinesterase inhibitor. So the enzyme cholinesterase, which is responsible for the breakdown of acetylcholine. So acetylcholinesterase actually breaks down the acetylcholine in the neuromuscular junction, in order to clear it up. That's very important. Now, if you make an inhibitor, if you inhibit that enzyme, which is acetylcholine esterase enzyme, if you inhibit it, then you will have a lot of acetylcholine abundant in the neuromuscular junction. So if a patient has myasthenia, his symptoms would improve because a lot of acetylcholine will go to the other receptors, and so it will improve. So usually we do that with a substance called hydrophonium. It's not important really to know the name of that substance. The important thing is to know that this is short acting. It acts only for about 1 or 2 minutes. So you select a muscle which is pretty much weak. It can be, for example, the deltoid muscle or even an eye muscle, and then you give hydrophonium and you see what will happen. So within 1 or 2 minutes, you will see, if you see the muscle improving, ptosis disappear, or the shoulder flexion becomes better, then this means it is a positive tensilon test. So this might indicate that there is a neuromuscular junction disorder. Of course, this test is not specific, and also Simpson's test is not specific. It can happen in other kinds of diseases. Actually, it can happen in myopathy, actually. So these are not specific. They are suggestive of myasthenia gravis, but they are not specific. To do more specific test, you can do an EMG nerve conduction study and ask for a repetitive nerve stimulation. So it's not just an EMG, you ask for repetitive nerve stimulation, which makes repetitive stimulation to the muscle by stimulating the nerve, of course. It will stimulate muscle repetitively, and that would cause fatigability in this muscle. And this fatigability will be shown clearly in the EMG. So you will see the amplitude of the compound muscle action potential decreasing more than 10% of its original amplitude, which is not normal. With normal people, it doesn't decrease so much. So in myasthenia, you might have 12%, 20% decrement, with repetitive nerve stimulation. So this is called decremental response, which shows fatigability on the EMG, on the electrophysiological studies. Also, you can do a single fiber EMG nerve conduction study, which will demonstrate something that is called jitter. Jitter is variability in contraction on the level of the myofibrils. Because myasthenia gravis is bizarre and variable, and so you will see this variability also electrophysiologically. Even those are actually not specific, to myasthenia. They can occur in other disorders, but they are highly suggestive of myasthenia. Now, what's specific to myasthenia more is to do the autoantibodies, actually. And now, these autoantibodies, which are anti-acetylcholine receptor antibody, which is the main one, this has 90% sensitivity for myasthenia, so it's very sensitive and pretty much specific. Also, you can also send for anti-MuSK, MuSK, all right, anti-MuSK antibodies or anti-skeletal muscle antibodies. So these antibodies, if you send for all these 3 antibodies, they are pretty much sensitive for myasthenia. They are more sensitive than the electrophysiological and the bedside tests. So these tests actually reflect the autoimmune response. You can also send for a CT scan for the chest in order to see if there is thymoma or not. Since in myasthenia gravis, about 85% of people with myasthenia gravis would have some thymic enlargement. Most of those would be due to benign follicular hyperplasia of the thymus. Most of them, like 85, possibly 90% of them. Only the minority of them, it might be due to thymoma, which is malignant tumor of the thymus gland. In that way, this also reflects, this is an investigation about the immunological basis of myasthenia. Also, since it's an autoimmune disorder, it might be associated with other autoimmune disorders. So you should send for a thyroid function test and sometimes other connective tissue secretin tests like anti-nuclear antibody and rheumatic RF, rheumatic factor, and other tests for autoimmune disorders. So this is pretty much the diagnosis of myasthenia. So that's the main diagnosis, of course. Of course, if a patient presents to you with myasthenia, you will also, not only these are the specific, workup for myasthenia, but you should also send the other routine investigations also. So this is pretty much the diagnosis of myasthenia itself. So suppose you have a patient which are unknown to be myasthenic before and he came into crisis. So what kind of crisis is that? Most of the time, 99%, if the patient didn't take any drug or is not intoxicated with something that has to do with the cholinergic agents, so most of the time is myasthenic crisis, which is due to the disease itself. So it's myasthenic crisis. So myasthenic crisis is crisis due to myasthenia itself. So myasthenia is becoming very severe and is presenting into crisis. Myasthenia causes muscle weakness, and one of the muscles that it might cause weakness in is the diaphragm and the muscles of the chest, including the accessory muscles. So if it causes weakness, severe weakness in respiratory muscles, then the patient will have a respiratory failure, and that kind will be kind of type 2 respiratory failure, in which he cannot wash out carbon dioxide. So we'll see hypoxemia and hypercapnia with that patient. So if you see a patient with respiratory failure, so he's in crisis, so this is mostly, most of the time, due to myasthenia itself. So drugs that help increase muscle power in myasthenia will improve it, can improve it. While with cholinergic crisis, it's the opposite. In cholinergic crisis, this crisis is due to increase in acetylcholine in the neuromuscular gap. Actually, it's due to a prolonged and sustained effect of acetylcholine. So it's the opposite of myasthenia. This actually occurs in patients, in myasthenic patients who are on treatment for myasthenia. And actually, it signifies over-treatment with acetylcholine esterase inhibitor. So, for example, the usual acetylcholine esterase inhibitor is pyridostigmine, or what is called mestinone. And now, if you start treating patient with myasthenia with mestinone, and you start increasing the doses, usually we may start with 60 milligram by 4, and then 60 milligram by 6, and then we increase it each 10 milligram each dosage. So sometimes you might go into excessive dosages. So this will cause abundance of acetylcholine and will cause sustained contraction of the muscle. And this sustained contraction of the muscle also leads to muscle weakness. because there is no repolarization. It's into continuous depolarization, so it will cause weakness. So this is called cholinergic crisis. Cholinergic crisis can be also accompanied with other manifestation of increased acetylcholine, like sweating, salivation, increased bronchial secretion, meiosis, and bradycardia. However, these clinical manifestations cannot by themselves differentiate these two conditions. In order to differentiate these two conditions, you should depend on history. For example, the patient didn't take any any drug that can increase acetylcholine in his body. So this would be myasthenic crisis, of course. If he's on treatment, or he took, you think he's intoxicated, like organophosphorus compounds or other, in a manner that increases acetylcholine in his body, then he might be with cholinergic crisis. In order to differentiate between them, you can do the tensilon test, the same test that we used for the diagnosis of myasthenia gravis. Now, this test, with tensilon test, if the patient's crisis improves, then it's myasthenic. If it worsens, then it's cholinergic. Now, how do we initially manage a patient with myasthenia gravis? You have two kinds of presentations. Some of the presentations, the patient actually come into crisis. He comes to you, he presents to you with crisis. Now, in this case, you should manage the crisis, and then you will make the long-term management. However, many cases actually they will come not like that. They will come underdiagnosed or undiagnosed, and they are not in crisis. In those cases, you begin the long-term management first. So let's let's see, how to initially manage a patient who comes to you with myasthenic crisis. If he comes into crisis and he cannot, you first ask him to count from 1 to 20 in one breath. If he cannot do that, then this is very bad, and you will send him for a pulmonary function test. Now, if his total, so if his vital capacity is less than, for example, 1.5 liters per minute, then this is very bad. So you must intubate him actually. Actually, the patient cannot blow a match, or you cannot even count from 1 to 20. Then you should send him to the respiratory care unit or to the intensive care unit. And there he might need an intubation if his vital capacity goes down actually. So he needs to be intubated. Usually we cut down all pyridostigmine and mestinon. We can give him antibiotic if he is in chest infection or any kind of infection. If that infection actually was the triggering factor, the stressful impact that caused the crisis, so we need to give a suitable antibiotic, but you cannot give fluoroquinolones at all. So there are certain antibiotics that are contraindicated actually in myasthenia. So you should give antibiotics that are compatible with myasthenia gravis and with neuromuscular junction disorders. Now, during that, you can give him IVIGs or plasmapheresis in order to curb down the underlying immune response that is responsible for this crisis. Usually, we stop the pyridostigmine and the others in order to decrease the amount of secretions, which can actually impair ventilation, and sometimes even can assist in increased infection and worsening of the patient's respiratory function. With cholinergic crisis, there is no role for IVIG or plasmapheresis because it's not due to the underlying immune response. And of course, you must stop the anticholinesterases, and you only possibly put him on intubation if he needs it, and of course he must be admitted into an intensive care unit till his forced vital capacity becomes more than 1.5 liter, and till the patient, I mean, he is very well. I mean, the cardiac and respiratory functions are very well. So, I mean, in order to this is about preventing actually myasthenic crisis. What I mean by that is the patient was admitted to the ward and he's in myasthenia, is not yet in crisis. So, what are you going to prevent him from going into crisis? So here you can give also IVIG in order to prevent him going to crisis and also initiate plasmapheresis. One of the nice scenarios for that is if a patient is going to have thymectomy for myasthenia. Thymectomy is a surgical procedure, so it is a stressful event for the patient. So you should administer plasmapheresis before the patient is going to do plasmapheresis. So this is a kind of preventing. These are preventive scenarios. I mean, if you know the patient is going to go into, I mean, he's worsening, myasthenia is worsening, and so on. So you need to either give IVIGs or plasmapheresis in order to prevent him going to crisis. And also, you can increase his already immune modulation therapy that you are giving him for his myasthenia gravis. Actually, to the management of patients with myasthenia gravis, I mean, regardless of he's having crisis or not. So the mainstay of management is symptomatic, like you give anticholinergics like pyridostigmine, which is mestinon, which is the mainstay of that treatment. And the other thing is to prevent crisis, like by giving him IVIG or plasmapheresis, and of course to start the immunological therapy, which is the disease, let's say, modifying therapy, which is the long run therapy. This is the chronic therapy that the patient will take, because as I said, that myasthenia gravis is a chronic disorder and is a chronic autoimmune disorder. So we need to have immunological therapy, chronic immunological therapy, that the patient will always take. Usually we do that with steroids, and we start them actually at low dosages, and we increase them gradually, step by step. Like we start with 10 milligram steroids, prednisone, sorry, once daily tablet, and then every 10 days we increase it by 10 milligram. And we can use steroid sparing agents with them, like azathioprine, in order not to increase the dose of steroid very high, in order to prevent, I mean, any possible complications of long use of steroids. So we can use azathioprine, or we can use Sandimmune, which is cyclosporine. So all of these are, I mean, immune therapy. I mean, all of these are important in the immune therapy of myasthenia. All right. We, of course, if a patient comes with generalized myasthenia, what we mean by generalized is not localized to the ocular myasthenia. If it's generalized, then you should do thymectomy. There are indications for thymectomy and contraindications to it. They are present in Davidson in a very beautiful way, so you can go to the Davidson and see these contraindication indications. A thymectomy is most of the time useful in myasthenia gravis and is done for most cases with generalized myasthenia gravis. Further immune suppressive medications like rituximab or cyclosporine, I mean, these are more very strong immunosuppressives. These are usually reserved for more refractory cases, actually. And so this is the main treatment of myasthenia and the main management of the crisis and how you deal with these crises. Now, if you have a patient, inpatient, I mean, in the ward, what are you going to do with that patient? I mean, he's myasthenic. Myasthenia has myasthenia. and he was admitted. Suppose he was well up till now. So how you should follow him up in the ward. So first, you should daily ask him to count up to 20 in one breath. And you should send him daily for forced vital capacity. So ideally it should be 30 milliliter per kilogram. If it's less than that, then you will send him to the intensive care unit. You check for signs of cholinergic hyperstimulation because we are giving him pyridostigmine. So he might have these signs and he might go into cholinergic crisis. And these signs are, as you know, salivation and bronchial secretions and meiosis and bradycardia, and sometimes also diarrhea actually. And sometimes if it's very severe, even fecal incontinence. And sometimes urinary incontinence if it's very severe cholinergic hyperstimulation. You check for the side effects of, if you are giving him IVIG or plasmapheresis, so you check for the side effects of these. And these have very known side effects, and you can have that as homework. Check for the side effects of steroids. This is very important. You can have hypertension, you can have diabetes actually induced by steroids. And on the long term, actually, you should check if he might have vascular necrosis of edema, if he have activation of TB. On the very long run, he might have, this is not in the ward, of course, this is outward, so he might have even osteoporosis and all of these things. That's why we use steroid-sparing agent to prevent all of these complications. But during the ward, you should check his blood pressure, and you should check for any possible infection, and you should check his blood sugar repeatedly. So you can have an impaired glycemic control or abnormally high blood pressure. If the patient has any infection, chest infection or urinary tract infection or a GIT or even skin infection, you must treat them vigorously and aggressively, because those might be the cause, might precipitate respiratory failure, which is crisis, all right, and can lead to death even. And since the patient is sometimes is not ambulant, so he's subject to venothromboembolic phenomena like DVT and pulmonary embolism. So we need to prevent that by administering subcutaneous enoxaparin, 4,000 if he or she is heavyweight, or 2,000 international units once daily. So this is pretty much how you should follow up a patient, an inpatient with myasthenia. Of course, you should take all the vitals. You will send him complete blood picture, ESR, liver renal function test, chest X-ray, as we do with most inpatients. And we do also sometimes ECG to check for any arrhythmias and bradycardias that might be caused by our, although they are not so much, by our anticholinergics. So that's pretty much how you follow up a patient with myasthenia gravis, and this is the overview of myasthenia gravis. I'm ready for any query you have or any question about myasthenia gravis. You need to read the rest of neuromuscular junction disorders present in Davidson, which is mostly the Lambert-Eaton. Since it's a very rare illness, I didn't encounter it here. It's very rare, it doesn't cause actual respiratory, it's not lethal, but it is a sign of paraneoplastic phenomenon. And actually it comes with incremental responses. Its fatigability is the reverse of that of myasthenia, and usually doesn't affect the cranial nerves. It comes actually pretty much similar to a nerve illness. It has autonomic and areflexia, and especially in the male, it can cause impotence. So it comes within the differential diagnosis of peripheral neuropathy actually, but in reality it's a neuromuscular junction disorder. That's all about Lambert-Eaton, myasthenic crisis. Its importance, very, 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 very rare, and its importance is that it signals a paraneoplastic condition, whether bronchogenic carcinoma or other kinds of malignant illnesses. But pretty much we concentrate on myasthenia because it's the life-threatening and more common condition. and it's easier to diagnose actually than Lambert-Eaton term. So here I conclude my lecture. I hope you understood the basis and the underlying pathophysiological aspects and its relationship to the clinical management, and how do we clinically manage these cases, how do we diagnose them and manage them actually. So thank you.